thank you for joining this Grand Rounds presentation on Transition in You, creating a culture to successfully launch our patients to adulthood with compassion. I'm Rhonda Katie, Nursing Research Specialist at Gillette. I don't recognize everybody's name, but hopefully you've seen me before. Before we get started, I want to share a few general pieces of information. First, the presentation's being recorded. You probably got that little message when you logged in. It's going to be available on the CME events page in Gillette, and I'll also be distributing it myself and probably Tori externally to other folks. Second, questions are encouraged during the presentation. Please ask, and you can do this several ways. The first is to use the chat function up at the top of the screen. You just click on a little thing that looks like a chatty thing, or if you prefer, you can click the button to raise your hand. Either one works. I'll be monitoring the chat box. If I can respond knowledgeably to the question, I will. Otherwise, I'll hold it for our presenters to answer at the end. Our speakers today are Tori Barr and Debbie Harris, and I'm privileged to work with both of these women on the Transition Task Force. Tori's an internal medicine and pediatrics physician with Gillette's Complex Care Clinic. Tori's been with Gillette just shy of 1 year, and during this time, she's worked endlessly to advocate for her passion, which is transition. Debbie is a tireless advocate whose work Debbie is a parent advisor for our Transition Task Force. She's a tireless advocate whose work at Family Voices, the Children and Youth with Special Health Needs Research Network, and ARC of the United States, and numerous other organizations that seriously I can't even begin to list, is committed to helping shape all civic, community, and health systems to seamlessly include people with disabilities and chronic medical conditions and their families. Debbie's passion is grounded in her most important role as mom to Josh, who you'll meet a little later in the presentation. And with that, I'll turn things over to Tori and Debbie.
Thank you, Rhonda. And thank you everyone for coming. I'm so excited to talk to you about transition and how we can really start creating this very important culture at Gillette to help serve our patients. Debbie and I have no disclosures to disclose today, and our objectives are that you will, 1, know what transition is, 2, understand how complex it is, and 3, leave with a toolkit so that you can start implementing transition into your practice, into your department today. So just so everyone's on the same page, definitions. Typically when transition gets brought up, what people go to in their brain is changing from one provider, so a pediatric provider, to an adult provider. And that actually is called transfer. So when we think about transition, transition is transfer plus everything else. So it's the skills, the processes that we are learning and developing in our patients and our families so that they can successfully navigate an adult model of care. We all know that there are patients that have an adult doctor that aren't thriving. That is not a transition. We want them to get to adult care and then really thrive once they're there. So,
Tori, I'm going to interrupt you 1 minute.
Yeah.
Can you go down to presentation mode? Your slides are not advancing. So if you go to from the top, from beginning. Oh, there you go. Or from current slide.
Yeah. Now? Are they advancing?
No. Try that one more time from current slide, right next to from beginning.
Slide. Does that work?
No, it's not working, and I don't know why.
No?
No, maybe just scroll down and you'll have to click on each one, unfortunately. Sorry about that.
Okay, I can do that. Everyone can see?
Yes, thank you.
Scroll these over. Okay, so my interest in transition really started when before I was a medical student, a college student. I was a PCA for one of Gillette's patients with SMA. And it was through this experience, she was in her early 20s, and really seeing the struggle she was going through and becoming an adult, that I got interested in this population. And it's why I chose to become an internal medicine and pediatrics physician, affectionately known as MedPeds. And it was during that experience in my residency that this even got solidified further. So I had my continuity clinic down at the Fairview Egan Clinic, and I actually worked there for a year after I graduated doing MedPeds primary care. And during that experience, I accumulated several Gillette patients who were in this transition to adulthood age and really fell in love with it even further. I also had the opportunity to work at both regions and as an attending as a hospitalist at the University of Minnesota, where I got to experience patients from Gillette having their first adult admission. And this was really eye-opening in terms of, one, understanding the patient experience, how terrifying it is and how much there is that is so different from pediatrics. And it also gave me the insight from being the attending of learning about how little our residents really learn about complex childhood illnesses as we age, and how nurses and system is just not set up for patients to be successful. And ultimately that led me to this job here at Gillette, which has been awesome. My practice now is in the complex care clinic, and I see about 40% of my patients are referred for some sort of transition related question. So we'll talk more about kind of what's happening in the future, but I wanted to make sure that we got introduced to Debbie and Josh.
I don't think I can. Oh, hi. Hi, I'm Debbie Harris, and this is my family. My husband is now retired from the Marine Corps, but that was quite a journey as well. But we have 3 sons, and our youngest is Josh, and many of you might be familiar with him. Josh joined the team at Gillette when there was a special needs clinic that we were invited to. And I think he was 1 year old. And so we've been there ever since. And now Josh is 27 years old. So it's been a remarkable journey at Gillette. Transition to us has been a really scary concept. And I think it's because of Josh's complex needs and all of the, just the dips and the mountains and peaks and whatever in his journey. And the relationships that we've had to form to become the advocates that we are, and the trust that we've had to develop with practitioners, and some of the experiences that we've had that have been really actually traumatic for us. And so just developing those relationships of trust and finding physicians and others who would support our journey with Josh. For us, that has been just such a treasure. And so the thought of having to leave that team was so scary. And for me especially, I feel like it's the reason we have Josh is because we've had such a remarkable team. And so when the concept of transition was first brought up to me, I felt like I was going back to the NICU days again, where you just didn't know from one minute to another if he were going to be with us. And so I felt like I was facing so much of an unknown. And if we left that group of people, that we would lose Josh as well. And because his needs are complex, and even though he's been stable, because we've learned so much about him from that same team, and because we've been able to be advocates enough to develop continuity and consistency in the people who come into our home to help us care for him, he's been really stable for a few years. But prior to that, it wasn't the case. And so I just felt like we would lose that and we would lose him. So it took a lot of convincing for me to even approach having an appointment for transition. And I think we were kind of the notorious, the notorious non-transitioners. So, but they finally got us there, and it's been an awesome experience for us. So now we're kind of cheerleaders for it.
Excellent. And we'll hear more about Debbie and Josh's story coming up. But I wanted to first start off with telling a little bit about kind of where transition comes from. So really, transition is a new field of medicine. And this is because pediatricians and places like Gillette are doing a much better job of taking care of these patients over time. So this is just looking at the life expectancy for a child born with Down syndrome. And you can see that over time, you know, in the 70s and 80s, teenage years was the average life expectancy. And now in the 2000s, we're up to life expectancies into the 50s. Another population that we take care of at Gillette is the Duchenne muscular dystrophy patient population. This is a Kaplan-Meier survival curve. So this compares, in the dark here, the 1960s, 50% of patients by age 18 or so were still living, as opposed to now, this was a few years out of date, but in the 80s, 80% of 18-year-olds were still living and thriving. So this is a new field of medicine that really adult systems haven't necessarily taken care of our patients in the past. We also know that healthcare is just not meeting transition needs right now. So this is a survey that came out several years ago, and they repeat it every 10 years. So it'll be really interesting to see what comes out here in the next couple of years. But they called all families that had children with special needs, and this ranged anything from a child with asthma to a child with spastic quad CP. And it looked to see, you know, how well is their healthcare system setting up? And they asked 4 questions. They asked, 1, did your doctor talk to you about finding an adult provider? Did your doctor or healthcare provider talk to you about what to expect as you become an adult about your healthcare needs? Did they talk to you about health insurance? And then did they encourage your child to take responsibility for the medical conditions as it is appropriate? And if you look at the number of patients that were given all 4 of these quite simple tasks, the answer was only about 40% of families. And that's what they defined as meeting transition needs in this study. And when they broke down the data, that there are things that make this even more difficult to achieve. So non-white, non-English speaking, below the federal poverty line. If the child had a developmental delay, less likely to talk about it. If they were on public insurance. And of course, what really is the Gillette population is those that have increased impact. So those that are more profoundly affected by their disease are less likely to have conversations about transition. So I'm hoping that Debbie can kind of talk us through what their transition process looked like as Josh started to age into adulthood.
Okay, thanks. Our transition process, it wasn't it's not a one-time thing. And actually, even though Josh is 27, I have to confess that it is still ongoing. And I think that might be the case for a lot of young people who have complex medical needs. It's not an easy thing at all. And I think because it's just now emerging. And I think because our kids are those who have kind of beaten the odds and we find ourselves kind of in this world where they didn't expect to be. There just aren't the maybe human, when I say human resources, I mean the medical structure set up to accommodate them. So for example, when Josh was discharged from the NICU, his prognosis was that he would live for 2 months, and then they said, no, never mind, it'll be about 2 weeks. And actually since then, really brought it up again. So we don't really have a prognosis, but he's 27. So we just don't talk about it. Like nobody talks about it. So we just like take it a day at a time, and he's 27. So, so when you talk about transition and your prognosis is 2 weeks or 2 months, you're taking life a day at a time. And in those early years when there were so many incidents and so many infections and so many surgeries and just odd things happening, that sometimes, we were told that, like, for example, he had a fistula, abdominal fistula, that we're told was a house of cards. We had an amazing surgeon who had the courage, like, to go in there and fix all of that. But it was a house of cards, but was approached really cautiously. But those kind of things come up that you just can't anticipate, and you don't know what your next day is going to be. So I think we're kind of famous for saying, we just take life 20 minutes at a time. And so a transition plan in our world is something that you almost don't even want to talk about because you're afraid that something will happen. And so we just didn't discuss it. We were so happy that we had this great team around us that would support us, that we never wanted to leave them, and we never wanted them to retire. And I think when the first person from our team did leave, I just cried my eyes out in the exam room, and I didn't know what else to do. I probably would have just like grabbed onto that person's leg and then and they would have to just like take me with them. And then pull Josh's wheelchair as well. But it's really difficult because we are still experiencing the kind of the PTSD from those early days. You never actually get over that. You never get over it. And I think I subconsciously, or maybe it's not even subconscious, but revisit it every year at the time that he was born, because that is actually extremely traumatic as well. Just to revisit that time that he came, and it was such an emergent and traumatic event. And so I guess just when you talk about, okay, everything that you set up to help this child survive, who have who've learned to respect you and to have conversations with you and to trust you, and you worked in partnership and collaboration with, we want you to leave them now and start over with other people who might not approach you the same way. And as a parent in this field, that the outcome depends on the relationship. And so what you're saying, what you're hearing is you're going to start over again, and there's a really good chance that this is not going to work out. And so, but the odds are against this time because your child is older and you're older. And so, the odds are really against you. And so for us, it was just like a deal breaker. We're like, no, thank you. Because we were approached, I think through physiatry, about moving on, and starting the transition process. And we were just like, no, thank you. We'll just stay here. But, thanks for mentioning it. But it took a long time. And then finally, we agreed to like having an appointment. And it was kind of an onboarding process. But I will say that the way it was set up initially, with having a psychology there and having social work there and have a nurse practitioner, and then also bringing in dietary, because that's a huge issue, and then also recreation, and just approaching it holistically, was really settling for me. It was a long appointment, about 3 hours, so we knew, we had to have a nurse with us, to tend to Josh's needs as well. But approaching it holistically like that made me feel better. And also being told that it was a process and there was not like a timestamp on it, made me feel better about it as well. So I think the problem is that there just aren't the practitioners out there to actually service us. So it's like trying to promise something and then trying to go find unicorns. You know, they're not there. So I was just fortunate. I picked up the phone and just asked questions, and we found a MedPeds person who's amazing. And when I rolled in there with our whole caravan, which looks, we look like a wagon train coming in. He didn't even blink, you know, and so that to me is like, that's like a really good sign. But yeah, so this is our family. This picture is Josh. I know it looks like he's in the NICU, but he's actually like really old in that picture. That's his transitional care unit photo, and those are Minnesota Vikings, probably senior citizens by now. And then this is actually our family photo from a few weeks ago. And those are all of our 3 sons, and that's our little dog, Claire. So, and we do manage Josh's care as a family unit. We have nursing staff in our home. We have 2 full-time nurses, and just recently brought on a 3rd nurse to help out because our oldest son, who's standing there, is married and has 2 small children, and was helping us to work night shifts. And he just said it was just wearing him out. And so we actually had to make a decision during the pandemic to bring in a night nurse we had trained earlier and put on furlough, because we were concerned about the fact that he did work in one of the major hospitals. So we were concerned about exposure, but he's really careful. And so we brought him in to help with night shifts to give our family some relief, because Josh is 24-hour awake care, and we just needed the extra help. But we work as a team. My husband has spreadsheets for everything, for med ordering, for disposable supplies. I do kind of the nursing management, insurance management. Our sons help out for nursing hours that aren't filled. And yeah, so we all work together to keep this machine going. So.
Debbie, thank you so much for telling your story. I'm wondering what age Josh was when he went to transition clinic.
You know, Josh was about, I'm going to say he was in his early 20s. We're always kind of behind. And I will say this, I've even tried to convince doctors, like, not to even have him go to the adult floor after surgery. I said, look, he's really small. He looks like a kid. I think we can pass. So, and it didn't work. But once we got up there, we were great. It was a good experience.
Yes. So we are going to talk now about transition at Gillette and what has all changed. So Josh has now gone through the transition clinic a couple of years ago, and he went through the transition clinic when it was located within the Lifetime clinic. That clinic was run by Kathy Lindstrom, nurse practitioner, and her crew. And as Gillette has really thought about transition being more than just a one-time event and more than just the transfer of care, and through Kathy's advocacy and bringing me on as a physician as well, the shift has really moved to that this needs to start sooner for our patients so that we can prepare them sooner. So as a result, the transition clinic is now located and housed within the pediatric complex care clinic. We offer basically all of the things that Kathy did in the Lifetime transition clinic, but then also having the ability to follow these patients over time so that it really can be more comprehensive and longer lasting. So when I came on, and as we made the shift from pediatrics, or moving the clinic over to the pediatrics world, it really came to light that we need to have some structure around this. So the transition task force that Debbie has been such an empowering advocate for and involved in has developed a new transition policy, which was approved this summer. It's policy A35, and you can see it on the Gillette policy app. But I wanted to go through a couple of key highlights from that policy so that everyone's aware. So Gillette recommends the age of transfer from pediatric to adult care be a joint decision between patient, provider, and family, based on the patient's individual needs and availability of Gillette healthcare system to meet those needs. So I think it's important to know that there is no specific age cutoff at which Gillette is saying this is when someone needs to transfer. It is really a joint decision between all of these players. It means that our providers have to have conversations with families about what their age limit is. And it means that you probably should start these conversations earlier so that parents and patients and families are not thrown off. And this is really in alliance with the American Academy of Pediatric policy of age limit on pediatrics. They say that having a strict age is inappropriate. It doesn't meet patients where they're at. And this is what we think transition should be at Gillette. It's meeting patients where they're at and helping them get to the next stage. So there are a few important ages to know though, because there are some age limits at Gillette. So on the 26th birthday, that is the age limit to get admitted to the Gillette PICU. And on the 40th birthday, that's the age limit for the Gillette OR. So those are structured ages that we have to work around. And that is also a structured framework that physicians and providers can talk about when they're having conversations about families about why their age limit is 26 or it is 25, or why they want to ideally get a patient moved over to adult care at whatever age it is. Practically speaking, we just want providers at Gillette to have the flexibility to determine their own age cutoff, because we know that they are the best, they have the best knowledge of what their skill set is. So this is an advantage that I like to talk to families about, because what happens is this is confusing for families. Why is it that Dr. Vandersteen says, I'm going to stop seeing you at 18, and Dr. Williams-Doonan says 21, and Dr. Barr says 26? Where does this come from? So I like to just flip the question and say, well, here's the deal. If you could see Dr. Vandersteen till 26, would you? And the answer is always going to be yes. I will see them until I'm 25 years old and 355 days, because the care that patients get at Gillette is unrivaled. It's amazing. But what would happen then if we just said all of the providers at Gillette are going to see patients till 26? Everyone would keep seeing all their providers until 26. And then when they turn 26, they need to find an entire new team, go to a new hospital if they get sick, all within 1 month. And that just is not setting patients up for success. So when providers can choose when they is appropriate, what happens is we kind of get some natural self-selection where urology hands off at 18. Neurology hands off at 21. Endocrinology says 24, and these are just practically made up, just so you can look. But it allows for this to be a stepwise, slow, controlled process, so that families aren't going through trauma of completely changing everything. Things can stay stable and make little adjustments one thing at a time. So in helping families kind of see this, when they come to transition clinic, this is what I create for them. So they get a transition roadmap. And basically I get a list of all of their pediatric providers that they're seeing. And then we compare that to adult providers and what the transition plan is. So here you can see this patient is kind of halfway in between their transition. So they have moved some things over like PMR, and neurology, but there are still several that they're working towards needing to find an adult provider for. And it's with this document that I've had really good success of sitting down next to a family and saying, this is where we're at. This is where we have to go. We have to find new providers for these specialties. Which one do you think we should work on first? And I think it's so helpful for families to be able to see the big picture of where we're going, and also to empower families to know that they have a choice of which ones they want to work on next. When it's just this very vague, like we need to change everything, and every doc is telling them something different, it's really complicated for families to really wrap their head around how this can be successful. So this is something that all of the patients will get when they come through transition clinic. I also share this with their primary care provider. And of course, it's right in my notes so that all of the providers at Gillette can take a look too to see kind of what is the big picture? How do I fit into this as well? Another part of the policy says that we expect providers to initiate transition between the ages of 12 to 14 and address annually. And if a patient is identified as high risk, refer them to social work, care management, complex care clinic. So if you're ever wondering about what you can do, you see this family and they're really like, you anticipate that this is going to be a very difficult, long journey for them. Then you can start having conversations with patients early about how can we help. So social work is great for talking about guardianship and just all of the mechanics that go behind things. Care management is getting some extra RN support to help along this journey. And of course, complex care clinic will be able to really get the bigger picture and create some of the documents that need to be created to have a successful transition. But one of the things providers give me a lot of pushback for is, why in the world would I start talking about transition when at age 12? Like, am I really supposed to tell a patient that, hey, when you turn 21 in 9 years, I'm no longer going to see you? And I just want to throw it back again to that definition of what transition is. So transfer is all about changing from one provider to the next. But transition is so much more than that. Transition is giving skills, empowering patients to really take responsibility and gain some independence. So we chose 12 to 14 in the policy because this is what all of the major organizations throughout the US are saying is when you should start transition. So the pediatrics, the internal medicine, the family practice docs all have agreed that this is when it should start. There's evidence based from the GOT Transition Organization, which is the national organization. And then also the organizations that are alive and thriving here at Gillette, the Spina Bifida Association, the Muscular Dystrophy Association, say that this is a key component that starts by the age of 14 years old. So what does this actually look like? How do you actually do transition at age 12? So really, age 12 is starting to just identify what the patient's abilities are, looking at different skill development that might need to happen for the family or the children, and then really just getting a sense of where they're at. So this can be things like having parents leave the room if that's appropriate to talk to the child for 2 minutes on their own. Or it can be at the front desk when they're checking in, having the child stand there with mom so they know what questions are starting to get asked when you go to check into an appointment. And then building on those skills as they go through the middle teenage years and starting to gather information about what are age cutoffs for providers. 16 to 18, we really need to solidify what the guardianship status is for patients and start educating around what the healthcare adult health systems are like in their area. So families are very familiar with Children's and Gillette and the university and what those things mean because they've been in those systems. But when they have to start thinking about adult care, they're going to completely different systems. The university, Health Partners, Alina, what does that mean? What does it mean if they want to be at Health Partners? What hospital would they go to? Where are those clinics relative to their house? Those sorts of things. And then thinking about as they turn 18 is when we're going to start moving over some of those providers and thinking really hard about that adult primary care doctor. So Gillette plays the role of primary care. Whether we like it or not, we become our patients' medical homes. They all are supposed to have primary care doctors that they go to for their vaccines and their pre-ops and their well child checks. But really, they see Gillette as their medical home. And that is something that we can't provide long term. So finding this adult primary care doctor really has to be the core of how they're going to be successful outside of the hospital. So a lot of the education around the adult health system that should happen kind of in the teen years is really kind of educating patients about what is the role of a primary care doctor? How do they help you? How do you advocate for yourself with the adult primary care provider? And then it's our responsibility as Gillette to make sure we're giving those adult primary care doctors the tools they need in order to be successful. We can't just drop off our patients at their doorstep and say, we've taken care of them for the last 18, 20, 21 years. Now they're going to be in your care. We need to think about what sorts of handoffs do we need? What sorts of information do they need from Gillette? How do they get a hold of us if they have a question? And letting them know that we'll always be here. When our patients are 30, when they're 40, they can always call and ask. And our physicians and providers are happy to provide that support of helping people get to where they want to go. And then thinking about how can we really track the success of this long term as patients are aging out. Now, some patients might end up going to Lifetime and staying within the Gillette system for some of their care. And I think it's just really important to note that even if many of them are going to be able to met at Lifetime, not all of their needs are going to be met at Lifetime. So regardless of who the patient is, this is a universal experience for all of our patients. And lastly, everyone at Gillette has a role to play in transition. So we are a big team, and the transition team really starts with you, no matter who you are. So if you are PAS and answering calls, scheduling a surgery, you're part of the transition team, because when you're scheduling that surgery and the patient is 18 years old, you have to ask questions about guardianship and having those conversations about, oh, this person doesn't have a guardian yet, and I'm scheduling this surgery. We need to figure that out. But you're not alone. Transition is not something that can just happen in a vacuum. And Debbie talked about how at her transition visit, it included a multidisciplinary team to really support her. And I want you to feel empowered that whenever you see a patient and you identify that they're getting older, no one's really had these conversations, what can you do? And there's so many things you can do. So we kind of like to think about this as like the primary or the core transition team. So social work and OT and PT, care management, therapeutic rec, psychology, the transition committee, and complex care pediatrics. These are people you can reach out to get support for a patient that you feel is just struggling through this process. We also encourage you to be the transition champion within your own department. So as we look to the future, we want Gillette to be a national leader in transition, because we know that we have an incredible group of patients that need us to help during this journey. We want to be there. We want to provide the care that they need, deserve, and really change the way that we think about transition at Gillette. So as we think about future directions of where this is going, and this is only going to happen because I have an incredible team with the transition committee, the things that we are really highlighting as what we want to work on in the future are, one, educating our providers. So doing things like this, this grand rounds. And I hope next year in 2021 to be able to do a transition boot camp, to be able to kind of talk about a lot of the nuances and really think about how can we start doing this work better from provider standpoint. Figuring out how we can measure outcomes. Advancing health equity so that all patients have same access to transition services. Doing some scholarship and using what we find and work at Gillette to be able to affect not only the people in Minnesota or the people in within the Gillette system, but really using our knowledge to share and grow transition throughout the country. We got to work on building community partners. So the only way that we're going to be successful in helping families find good primary care docs is if we help primary care docs feel comfortable with our patients. We want to engage our patients and their families and really think about where can we meet them to learn more about transition, empowered to ask those questions, to have the resources to know what Health Partners is and Alina is, and help them make decisions as they're coming up on transition. This is not possible, like I said, without an incredible transition committee. So we have several members, and most importantly, our parent advisors, who have been incredibly helpful along the way to help us learn about what this practically means for patients, as well as a couple community partners that really are key to thinking about how we can do transition better. One thing that we know is that transition is not just about doctors and finding the right doctors. It is about learning how to navigate in a new system, and then all of the other stuff that's going on. So nursing and insurance and navigating day programs and education and vocation. And how can we do that better? And we have to bring in the community partners, because Gillette in and of itself cannot do transition all of it. It is too big of a journey for families. So we need to think about what can Gillette do very, very well, and where are our community partners to really help us along the way to fill in those gaps that aren't our expertise. So how do you get involved? So I think there's many things that anyone at Gillette can do. First, you can just start asking questions. So ask the question in your mind about, how is this policy or procedure that is getting asked of me going to foster or hinder transition? Ask the question so that you're making it better for patients. Engaging families, so encouraging families to think about the future, their goals for the future, and join. So you can be the transition champion for your department, and you can be the one that is asking these questions at the meetings that you're going to, and trying to figure out how can we best support our families. And of course, we would love for anyone to join our transition committee, to get involved and to really think creatively about how we can do this better. I think what has been most amazing is thinking about how different levels of, or different departments and groups of people at Gillette do transition work. So for example, having the scheduler, when they're calling and scheduling an appointment for a 17-year-old, saying, hey mom, can we do this on speakerphone so Joshua can listen in on what's going on. Also, I think it's much easier to think about transition for our patients that have muscular dystrophy or spina bifida, that can really actively engage and have conversations one-on-one with a provider about what their hopes and dreams are. And we have to really think critically about, how do we do that same excellent work for families like Debbie's and Josh, where he can't tell us that I want to do this, or I can take on this responsibility. How do we best support them, and what does that look like? And that is why our patients and our families are such a crucial part of thinking about transition. It's also the part of transition that is way, way, way underfunded and understudied. And this is where I think Gillette has an opportunity to really make a huge impact for the future. So, with no further ado, we would love to take any questions. And of course, we would also love you to think about how you could start practicing and implementing transition today in your own practice. What might you do the next time you see a 17-year-old on your schedule, or that you're rooming, or that you're talking to on the phone? How can you do transition right now? Thank you so much. And Rhonda, we'll let you, if there are any questions.
Well, there's nothing in the chat box. So if you folks just want to unmute yourself, raise your hand, whatever, and ask questions, that would be awesome.
Hi, it's Diane. Tori, I was just wondering where we were with the transition flyer.
So we are working on a transition flyer to be able to give families. So when you are meeting patients and they're wanting to learn more about the transition program, that they would have a resource. And it is in process in the very early stages. So stay tuned.
Ketsa, do you want to ask your question?
Yeah. First, I just wanted to say thank you guys so much for this incredibly important work. This was a great presentation, and I think it's fabulous that we are highlighting this work here at Gillette, because there could not be a place that it's more important, in my opinion. But I did have a question, and it's about, I think far too often I encounter a patient who is already in the midst of transferring care to adult providers, or maybe even already has majority adult providers, and is still tied to Gillette, because they are going to Lifetime for PM&R or something like that. And I identify that this transfer went terribly, and they're struggling so much. And maybe they've never really been connected with the complex care program. Mm-hmm. And so I don't know, other than just saying, Tori, help. I don't know, which I've done a couple of times. I don't know kind of what is that next best step for a patient like that I'm identifying, still connected to Gillette, but already well into that transfer process.
Mm-hmm. So one, they absolutely can come to transition and complex care. So we are happy to see patients kind of as a 1, 2, 3, 4 time, let's help you, support you through this transition process, even if they're over the typical complex care age of 26. So I see those patients, Dr. Neerman will see those patients as well, being med-peds trained. So we're happy to help out in that situation and just kind of help take a step back and look at the bigger picture, because that's the real issue, is that what happens most of the time is that it's a very piecemeal process of endo says, okay, you're going to go to health partners, and neurology gets scheduled at Meg, and all of a sudden you have a patient who has a primary care doctor in Alina and all of their specialists in every other system. So one of the patients I saw several months ago had their adult care spread across 7 systems, and there was not a single system that the primary care doctor, or a specialist that was in the same system as the primary care doctor. And if we think about setting up a primary care doctor for success, like, that is not doing that. Primary care doctors are incredibly strapped, and we need to make it as easy as possible for them. So in that situation of this older patient kind of in the flux of things are happening, but they aren't well connected, we're happy to see those patients and kind of help get them on the right path to thinking about the big picture again and trying to fill in those gaps for patients. Did that answer the question, Ketla?
Mostly, yeah. I guess I was also looking for just logistically, because I have kind of heard different feedback, not from you or Micah specifically, but sort of like, it's too late to establish with complex care when the patient is already in their 20s. And so, I think maybe there's just some mixed messaging going on there. So I guess logistically, does that mean that I just literally reach out to you and Micah directly, or is there another way to do that doesn't kind of overburden you?
You certainly can reach out to me directly, or Diane Swayze, my admin, and then we can figure out a scenario, the best case scenario for these patients.
So, Tori, there was a question from Esme. Is there an order in Cerner to put in for the transition clinic? I think we need to clarify that transition clinic no longer exists.
Right.
Or I'll let you.
Yeah. So I don't even think if transition referral is still in there, you can put that order in and it will get routed to complex care. But really, all you have to do is put in a complex care visit. You can say reason is for transition. The goal over the next year is that all of the complex care clinic providers will get training and focused learning on how to do transition, because what we need at Gillette in general is just thinking about how to make things sustainable. And building a program around one person is not sustainable. We want this to be a culture that every person in Gillette is thinking about, so that transition is not just complex care care's thought process, but that within complex care itself, we all can provide the same level of excellence in thinking about how we can help support families as they go through this process. Of course, most of the providers in complex care are pediatrics trained, and that leaves Micah, Dr. Muirman, and myself to really take the older patients on, which we are more than happy to do.
So I want, Diane, did you get your question answered? I think she has a question about the slide.
Yes, I did. Is my hand still up?
Okay.
Okay.
Okay, excellent. I just want to make a couple of comments to what Tori had presented. So Tori, Debbie, and I also are participants in a nationwide care coordination project called the COIN, if you guys have heard of that acronym used. Several of the COIN sites are also focusing on transition, and trust me, nobody has this figured out. So we're not alone. It's really, it's hard. And honestly, having Debbie's voice and our other two parent advisors, Kathy and Tracy, kind of articulate, it's not this one and done transfer of care. It's a years long process and needs to be done slowly. And adult providers aren't the only folks struggling with this. You know, the children with medical complexity are growing up to become adults with medical complexity. And not only is the healthcare system not really set up to handle that well, but also all the social services that go around with adults are not set up to handle it. So, you know, parents and guardians kind of have a double whammy trying to navigate both of those. So just to kind of keep that in the back of your mind. And then the other thing, in one of Tori's slides, she mentioned one of the first steps, kind of identifying goals, kind of where a child family is at. Tori's per the transition committee, we're in the process of piloting some different transition readiness assessments. And again, they're not meant to score somebody on how they're doing on transition, but as a conversation starter. First, what decisions does the adolescent want to be a participant in, and kind of go from there. So the work of that group will be ongoing. And with that, I'm going to be quiet.
Debbie, is there any other thoughts that you have, being a parent, of what you would want Gillette employees to think about to meet patients where they're at?
I guess, and this maybe is not answering your question, but one of the things that was really beneficial for us in kind of going through the transition process at an older age was being part of palliative care, and just having someone who could deal with multi-organ systems in a complex patient. And that's something we hadn't had before. And I know that people misunderstand the concept of palliative care, but just understanding kind of the new scope of that, and having a physician who could kind of address just having Josh become comfortable and content in dealing with underlying pain and management, and kind of looking at him like more from a perspective more holistically, and not just treating each thing separately, but looking at him as a whole person, so that he would just be happier. And that made a world of difference, because it not only changed his life, but it changed our lives too. Because anytime that he's not anxious and not happy, it makes me the same way. So it really kind of changed the dynamics in our household. Not that we're upset or anything, but if he's sad, then it makes me like sad to see him that way, or if he's not settled. And so just seeing him so content and able to enjoy life and enjoy the things that he likes to do, audiobooks and movies and podcasts and so forth, just by having that addition to his care. And so I think just for staff to like think outside the box and add things, add maybe components to care that might help in ways that you just don't anticipate, makes a world of difference sometimes.
Thank you. Any other questions? Well, thank you so much for joining us and learning about transition. And we really look forward to, doing more teaching and learning and growing together as a Gillette community to really help serve our patients in this very important way. So thank you very much.
Thank you, Dr. Barr, Debbie, and Rhonda, everyone today. And certificates of attendance will be along with the survey. Thank you.